Now, our next session will focus on how we can make the best decisions around investing in innovation. And for this, we're going to be connecting over to the United States to Andrea Feigl, Chief Executive Officer and founder of the Health Finance Institute. This keynote address will be followed by a Q&A with our virtual audience. And here again, as ever, you can submit all your questions through the live question forum on the Summit platform. But for now, let's welcome Andrea.
Thank you so much. And dear organizers, esteemed cancer and chronic disease leaders, it is my great honor to partake in this important conference today. And I'm very grateful to have this opportunity to both share my reflections and some recent findings of our research. How can we make the best decisions around investing in innovation? This prompt reminded me of a quote by Nobel laureate Daniel Kahneman, who wrote that one should judge decisions by how they are made and not by their outcome. One should judge decisions by how they are made and not by their outcome. He further describes how the world is more unpredictable than we think it is, and that we overestimate positive and underestimate the likelihood of negative outcomes. Now, what can we learn and apply from this body of research on how we think and how we make decisions so as to optimize the outcomes of cancer prevention, treatment, and control? I argue here that without taking into account how the majority of decisions in investments and policy are made, those of us who have seen the light both about the growing health and economic burden of cancers as well as the ROI of early prevention and diagnosis can bring, will always be a step or a dollar behind in our advocacy efforts. Here's why. One, it's because of the availability effect or the priming effect. The cost of inaction on chronic conditions is not penalized fast enough. Investment and reward, or lack of investment and thereby failure of financial growth, have a severe time lag. Conversely, events with high prevalence and of emotional intensity receive a lot of actions and investments. Two, we engage often in system one thinking in global health policy decision making as opposed to system two thinking. And what do I mean by that? It's basically the system one type of thinking is where there's a fast, automatic, and intuitive approach to decision makings as opposed to a system two approach, which is more measured evidence approach to decision making. So investment in infectious diseases are important and urgent, and investment in cancer treatment and prevention and health system uptake of known interventions are important and perceived as non-urgent. So the reality that ensues is a reality where we as societies accept a 4 to 5% drag on GDP as a status quo when it is brought about over a long period of time. When it comes to pandemics and sudden market crashes, albeit of the same magnitude, they make headlines, are met with massive stimulus packages and moonshot vaccine races. So you can see where this is going. Collectively, we don't make decisions that weigh the evidence measuredly. Rather, we are prone to strong biases that lead to bad decisions when looking to optimizing health outcomes and financial returns. We respond to the proverbial mosquito bite with great rigor, but ignore the elephant in the room. So recognizing that at least these two biases exist and prevent us from making the best decisions, what are some of the solutions to addressing these challenges? So perhaps what we need is a checklist, a decision-making tool that cuts the noise in our biases and offers sort of a neutral nudge to steer us collectively in a direction where we optimize healthcare budgets at the national and at the implementation level. At the Health Finance Institute, we focus on connecting the dots between who makes the investment decisions and who benefits and who pays. So we recognize that especially in resource-poor settings, a blend of capital is needed to reach the diagnostic and treatment targets that are set forth by the Sustainable Development Goals. So the way we address sort of a bias priming that it's too expensive to invest in cancer diagnosis, for example, is by using investment and business cases that spell out very specifically who benefits, who pays, and what the cost of inaction is. What needs to be done specifically is, however, that one, it needs to be made clear that not every financing mechanism fits every problem, and that two different players have different roles in financing cancer care and solutions. And perhaps as a third point, it's in the end not just the economics and ROIs that should drive decision-making processes, but it's also about ethics, priority to the worst off, and the human right to life. So over the last 1.5 years, we have undertaken a research project with colleagues at the Harvard Chan School of Public Health to study what kind of financing works in what types of settings. So after studying about 10 years of financial decision-making in the blended finance space, we have found that blended finance, or a mix of public and private capital, works well when it's applied towards commodities and equity play in global health. And so it can be a solution in the pharma and diagnostics innovation space for cancer care in low and middle income settings. Further, blended finance actually has also worked in behavior and policy change programs, but mainly in high-income countries, because there are stronger data systems and reliable outcome payers that already exist. So it means that for ensuring private sector investors to come to the table for cancer investment and innovation decisions, there are clear areas where ROI and economic type of arguments can be very helpful in driving better decisions. Further, we've also developed a checklist that looks at these criteria where certain investment decisions and blended finance projects can work. So where we can invite the private sector to come to the table as well. So that there needs to be a clear definition of investment, stable data systems, favorable regulatory environments, stakeholder buy-in, minimum transaction sizes, and understanding the political economy and environment. Now, I know that was a very high-level treatment of the topic of investment decisions regarding cancer innovations. But the fact that we are looking at statistics such as those that were mentioned yesterday, that 40% of the cancer burden is actually preventable, but very little is done about it, that key leaders yesterday and generally in the media have mentioned that it's less about technological innovation, but more about system-level innovation. And that even in countries such as the UK, 45,000 persons were actually not diagnosed in a timely fashion due to the focus on pandemic during COVID. They weren't diagnosed in time for cancer. Making wise investment decisions at the national program level is more than just about the right metric. It's about acknowledging and addressing the biases and the noise that crowd out our collective ability to make the best investment decisions, those that optimize health, human capital, and wealth at the same time.
Andrea, thank you so much. Andrea Feigl there. And I know you're going to stay with us because we've had lots of questions in from the audience, as we've had over the last 2 days as well. First question to you, Andrea. How can we promote equity in investing decisions?
Well, a very, very big question to start out with.
There's a couple of examples here. For example, where you have like older adults who may not show the same return on investment in terms of lives saved, or indeed for children and childhood cancers that are often kind of like just small groups as well.
So there are currently frameworks that take into account not just the economics or the cost effectiveness, but that also look into like the socioeconomic status, giving priority to the worst off, give priority to those life-saving interventions. And then there are different ethical approaches, and it comes really down to what does a society or a particular context value the most. To give you a couple of examples, is that, basically there's something called the life course approach, right? That over the course of a life, everybody should get the same chance at life. There is an approach that gives priority to those in more disadvantaged settings, socioeconomic settings than others. So as long as we are aware of that and there's sort of a consensus within a specific context, it's hard to define sort of a right or wrong.
The second part of that question, which you may have answered actually, but is can we achieve cost effectiveness and equitable allocation of services, or are those two separate things? They can't go hand in hand?
I think it's sort of you basically optimizing for two variables. This is sort of how we look at that, right? Where we basically saying so what outcomes do we want to achieve where, and cost effectiveness alone. So cost effectiveness alone should never be the only decision-making criteria. We have done that actually in the U.S. In Oregon, and then basically C-sections, for example, were for example not recommended, and there was a huge outcry about that. So so I think cost effectiveness at the population level is a good guide, but at the end of the day, you have to decide you have to make a decision that factors in both the ethical component as well as the economic component.
And with that, then, how can governments bring in all of these different views and all these different components, and of course, in this particular case, the voice of the cancer community when looking at which policy innovations might actually be adopted at a national level?
Right. So I think there's an example of research that, and it's called extended cost effectiveness analysis, or a priority setting frameworks that already take into account these metrics. So it's a more, plus I think it needs to be a conversation between an ethics council as well as economists in the same room to make those decisions. So it should never be up to economists alone to make life or death decisions.
Another question that's come in, do you think the NGO sector is adequately knowledgeable or has the expertise to consider the financial solutions to health issues? And if not, then what can be done to address this?
So I would actually say it's not just the NGO sector. I think it's actually also in government that's the or in ministries of health, sort of the financial literacy around, how do you make the wisest long-term investments in healthcare and outcomes is actually quite low. So and I don't want to tout my own horn, but we actually work, what we discovered at the Health Finance Institute over the last 3 years is that the understanding of financial terminology and how to apply sort of like economics research and even economics and ethics research on priority setting at the systems level, so that translational piece is actually missing, and that has to do with how we apply research. This is how we train our healthcare leaders, and this is about sort of feasibility building within the system to be able to respond to kind of more a measured or metric type or evidence-based approach to decision making within healthcare.
A question that's just coming in, would you advocate for a global fund for cancer care as an innovative approach? I'm
getting lots of hard questions here this morning.
Sorry, they're not from me.
So I have long argued for so what a global institution does, if you have a global fund for cancer care, it signals that cancer is important at the supranational level, right? It becomes no longer an issue of just national focus. It becomes an issue of global solidarity. Mm-hmm. And in that sense, I think it would be a good thing and an important thing to have. However, there are going to be issues such as, is this going to be a vertical fund? Who would pay into it? Is it again a sort of a colonial way of doing global health? So I think that if it's done right, absolutely yes, but it depends.
Okay, well, that's all we've got time for. I apologise for the tough questions, but thank you for answering them so eloquently, Andrea Feigl there. We very much appreciate you spending the time for the World Cancer Leaders Summit. Thank you. We are now going to take a short break, and when we come back, we will have our live rap performer, Baba Brinkman, who will, again, need your input to make this particular performance work. So don't miss it, and I'll see you very shortly.